What I'm going to talk to you today about is our recent work in my lab recording directly from the cortex of humans, both acutely intraoperatively when they're having surgery to remove brain lesions, particularly tumors or vascular malformations, and that's acute in the operating room, and then chronic recording of people who have grid electrodes, as is shown in this rendition, placed on their scalp for 4 to 7 days. And what I'd like to get across is I think this approach has provided a new insight into human cortical function. It turns out I think the dominant rhythm tracking most human cognitive operations is ultra-high frequency oscillations in the 70 to 200 hertz, which previously had felt not to occur, in part because you can't record them on the scalp. So let me see if I can convince you of that. And I will start first by discussing briefly the EEG spectrum, and there are many forms of things you can study in the EEG. This is your log scale of the spectral content, event-related potentials, which I've done a lot of work with, but I'm not going to discuss. In animals, you get frequency oscillations up into the couple hundred hertz range, ripples. In humans, it had been felt pretty much that around 60 hertz or so, not much else happened. And I think really, again, it's because you don't see anything on the scalp. And many people who even did intraoperative recording in the past 15 or 20 years simply put their bandpass here to get rid of 60 hertz line activity. So now, what I'm going to show you is that, in fact, when you open up your bandpass on the human cortex, the dominant frequency is really well above the low gamma range, which has its own interesting properties that I won't talk about today. And I do believe it is related to issues related to binding, but actual information flow is really being tracked from 70 to 200 hertz. And I won't say much about fMRI other than to say that, as most people who are aware, Logothetis' work in 2001 showed that oscillations in the 70 hertz peak and all the way up to a couple hundred hertz actually were the best predictor of the bold signal. Not that LFPs and signal units didn't predict, they were just the best. And a recent study appearing in Science by Mukamal and colleagues again showed if you looked at lower frequencies, below 30 or 40 hertz, they inversely correlated with the bold signal. So the higher your frequency, the more likely you were to get a correlation between bold activity in fMRI and local field potentials, in this case, oscillatory activity. Now, I will not show you our correlation, but you will see as this talk unfolds that we find the exact same thing, that the high-frequency oscillations occur in precisely the areas that other investigators have reported fMRI activity and PET scan activity. So first, how did we get into this? I got a very fortuitous letter from the chair of neurosurgery saying that I do language mapping in the operating room. The procedure takes 45 minutes. I need to make it faster, and nobody wants to help me at UCSF. I said, hallelujah, picked up the phone, called him. Now let me show you where he sits in this history of stimulation mapping. And I'll tell you what that is in a minute in surgery. Stimulation mapping is applying current to the cortex and evoking either a positive thing like a motor activity or disrupting some function such as language. And it was first reported in 1870 in studies by Frisch in dogs. The great neuropsychologist Fourier showed it in monkeys, and he mapped out also visual and auditory areas and then used stimulation mapping to get the motor structure. Sherrington took it into primates. Penfield extended it into his famous homunculus in humans. Penfield then in the 50s extended it into determining language. And this is where it split. Here was active stimulation. Put current on the cortex, see something move. Here, put current on the cortex and disrupt the function. Okay, so it became a disruptive technique. Penfield trained Ogeman, who is up at Washington University. Ogeman trained Berger. And Berger's the guy who contacted me. And that's Mitch Berger. That's 3 Berkeley grad students, Ryan, Eric, and Miriam. And this is what we started with. Mitch, in stimulation mapping, patient has to take out some lesion, whatever the lesion might be. They want to spare language cortices, and the only way to find it, fMRI won't do it effectively pre-op, is to actually map the cortex electrically. So the patient's put under surgery, the brain is exposed, patient's nose is up here, the anesthesia is removed, the patient's awake, and 2 things happen. Mitch has the patient count 1, 2, 3, 4. He applies current to the cortex. Wherever the patient goes 1, 2, and can't speak, that's a language output area. He then shows the patient's pictures, let's say a picture of a cup. If the patient says, I can't get the name, that's a naming site. Okay, it's as simple as that. The problem with this procedure, to map the whole cortex, he has to go back and forth over multiple sites. It takes 45 minutes, and somewhere between 1 in 5 to 1 in 10 stimulations produces an epileptic after discharge. And if it spreads in the operating room, it's disastrous. The way they treat it, just to let you know how crude this is, and this is not a reflection on Mitch or the surgeons, this is the state of the technique. If they have an epileptic after discharge, they have a vial of ice water. They take the ice water, they squirt it on the cortex, and it shuts the cortex down for a minute, and then they resume the mapping. Because if they gave a drug, the patient's out, and they can't continue the mapping. So that's what he wanted to replace. So here's some mapping sites from Mitch's work that we reconstructed for him, and it'll show each one is an individual person out of 100 and something cases. Wherever there's a dot, the person couldn't speak, speech arrest. Wherever there's a dot here, the person couldn't name. Notice that they're spread all over the place. They're all in the Perisylvan language area, but they're not in one spot. That's why you need to know in that person, because if you went in here, you might end up with someone who had a problem with language in that person. So you really need to precisely know. So that's what we're trying to replace. Now, since the first talk by Larry had violence with fire and Terry jumping on the fire to put it out, and then Kwabena had the robotic brain of the future, I thought there was only one thing left. This is being webcasted, and that's sex. So I put a couple sex slides in here. I'm going to show you that when you start looking at, you break these down by male versus female, here's speech arrest by sex, okay? And this is our 95% confidence interval. And each one of these is a person. And there's no difference in speech arrest. So males and females have the same organization for speech arrest. However, if you look at naming, there's a completely different distribution. Men have speech arrest at frontal sites where women almost never do. So there's a language effect on this organization of language. If you move to age and look at our kids under 20, or 20 to 30, and so on, because we have a range of people, speech arrest, there's no effect of age. Independent of age, independent of sex, the same area, if you stimulate it, you have trouble speaking. However, if you now look at naming is significantly different by age, and the older you get, the more focal your naming site is. So these are all the kind of things the surgeon really needs to know, and that's why these people have to map. So this thing's not going away, and we decided we'd try to help them. So the first thing we did, we knew because of the stimulation sites, we'd get language cortex exposure in every case. And we knew there was a brain phenomenon called the mismatch negativity that we knew was generated there. And we decided, we don't know what we're doing, so we better start with something there's literature on. So we started doing this simple mismatch. It's a little bit out of phase. You build up a template and you break it. You get this brain mismatch. We knew it came from here, and we reasoned, this is a good way to start. If we don't get this, we're in trouble. And I won't show you the evoked potentials. We got the standard mismatch potentials. And this is our first patient to the deviant. Beep, 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 boop. Break the template. And for some reason, we had our bandpass up to 80. We probably should have had it at 55 to get rid of line noise. Here's onset. Here's the 400 milliseconds. And here's a sliding FFT. We've done it with that and with wavelets. And what you can see is you get a lot of power in the low frequency components, which, by the way, is very coherent in nearby electrodes. And we noticed that there was a glint of power in the high-frequency band. Maybe it was an artifact. We basically, in the next person, and this is obviously that person, we opened up that band. And what it turns out is there's this cloud of high gamma activity. So our first thought was, it's an artifact. We screwed up something because it's not supposed to happen. But when we looked in the literature carefully, it turned out Nathan Krohn at Johns Hopkins had reported high gamma in the motor cortex in 1998 and then again in 2001. So we thought maybe it's real. Maybe it's a real phenomenon in the human cortex. So we decided to go to a second simple study where we go and presented phonemes. We chose phonemes because, again, phoneme deviant, beep, ooh, 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 ah, or ah, 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 ooh, I can't remember here. And we figured, we should get the same mismatch negativity. Let's get away from sensory characteristics and have each phoneme, the phonemes basically spoken by different people. So we're away from the sensory characteristics. We're more into the perceptual characteristics. So when we do that, here's what it sounds like.
Ooh, ah, ooh, ah.
So when this infrequent ooh occurs, again, just like with the tones, time frequency 0 to 600, 0 to 180 hertz now, you can see this cloud of high gamma activity in every subject in the superior temporal plane, anterior to the area that we got the tone mismatch. And so now we were kind of confident that we had something. By the way, the lower frequencies, and this is ubiquitous, lower frequencies tend to lose power. So stuff between 20 hertz drops. So low power, drop in power, high frequency, increase in power. I'll get to that in a minute. The answer is from talking to colleagues who do monkey research, and Pascal in one, it may be 2 to 3 millimeters. And we've actually, you'll see, we've got a new grid that we're actually studying that right now. I'm hoping it's 2 millimeters because it's more information content. That's what we're hoping for, but we don't know. Just a little thing we thought, well, this is pretty cool. We're one of the first people to find this high gamma response, and it turns out one of my grad students is very good at history, actually trained with Scott. Eric Edwards did a careful search, and in 1936, Leon Echters reported that in the rabbit, if you gave orienting stimuli to the rabbit, he got high frequencies in the rabbit cortex up to 80 to 100 hertz. So actually, this has been floating around since 1936, a long, long time. A little historical fact. Now, the intraoperative stuff is very tough. We have 8 minutes to record the data, 8. And it's not easy, and some of the patients can't tolerate it. We want to continue that because we want, as I'll show you in a minute, take what we found in our chronic recordings and help the neurosurgeon get rid of that mapping procedure. So we're never going to stop working with the acute cases, but it's tough. What happened is, I think, as we got more instantiated at UCSF, we got connected with the neurosurgical program for epilepsy. And about 20% of epileptics have intractable epilepsy. And it turns out about 70% of that 20%, if you can localize the epilepsy, you can get either a complete control with medications or a complete stop of the epilepsy. Here's what they get. This is what's put in, and it is basically, before, remember, we just had ball electrodes on the surface, and we only had about 8 or 10 of them. Now a grid of 64 electrodes goes in with a 1 centimeter spacing, 2.3 millimeter exposed area. And this is what the grid looks like. We know where it is in each patient. That's rendered on that patient's 3D MRI scan. The surgeon will put additional strips under orbital frontal cortex and under the temporal lobe, and they're implanted for 4 to 7 days. Okay? This is great. So our research team goes over, the grad students and postdocs, and what we've done in our first series of now 7 patients is we've done 11 experiments in each patient. And the patients like it because they're sitting there bored waiting to have a seizure. And so there's plenty of things that this kind of occupies them. So let me just take you through what we found because it replicates the acute intraoperative stuff but extends it. First, this is a time frequency plot. Again, we're up to 170 hertz. This is stimulus onset. We're going for about 500 milliseconds. Patient doesn't do anything. This is the superior temporal plane. So these are auditory areas. And this is superior temporal plane. We play a simple tone. We get high gamma. There it is. We give more stimulus complexity. We give a phoneme. The activity moves anterior, just like we found acutely, and it's more distributed. Notice power in the low bands desynchronizing. We make a more complex stimulus, a word, and massive high gamma all over the back part of the brain, extending for the duration of hearing the word. So 400 or 500 milliseconds, temporal plane, and even some parietal sites. Again, lower frequency bands desynchronizing. I think you can see it's pretty clear that this high frequency band is carrying pretty much all the information in terms of this person hearing that word. Now, this is passive. Notice in the passive task, nothing's happened in the front of the brain because they're just passively listening to stuff. So let me show you, if you ask the person do something active. In this case, we're going to ask them to detect a phoneme in a stream of phonemes. So first, this is another patient. Here's the superior temporal plane. Just to orient you, here it is, right here, sitting there. And as you saw before, in this particular case, even more extensive phoneme activation, sitting in this temporal in the temporal plane area. Note, we've started to get smart, not because we're smart, but just because we had to. We now open it up to 320 hertz because there's activity up to 250 hertz and above in some areas and in some subjects. And this is passively listening to the phoneme. Now, in that series of phonemes, ooh, 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 ah, let's say, okay, detect one of them. I want you to press a button whenever the ooh or the ba or whatever you designate the target is. And what I want you to notice is two things. A, the frontal cortex is going to come on board. And B, the amount of processing in the sensory areas is going to be prolonged, as if there's a top-down influence between these two areas. So watch this. Extend. Much more processing of the phoneme when you're now detecting it, and the frontal cortex comes on board. So you're now showing this large-scale neural network being engaged during a cognitive operation. And this is actually my main research area is frontal lobe function, but it's the only slide I'm going to show you. I can just tell you that if you look at conventional, the tests everybody does, working memory, same thing happens. Working memory load is tracked by high gamma in the frontal lobe. So, I'm sorry? Yeah, we're going to get to that in a minute. There's a theta increase during a working memory task in the frontal lobe, and I'm going to get to that. You're very good. Can you come work with us? We need help. That's very good. Okay, so now let me show you a more complicated task. A little bit more complicated, but not that complicated. It's called verb generation. So I need help from somebody. Larry, can you help me? Okay, all I want you to do is to say an action verb when I tell you a noun. Ready? Ball. Bounce. Thank you. That's the task. So we present the patient a series of action verbs, and all they have to do is produce to that action verb, to that noun, an action verb. And what you're going to see, what we've done here, this will give you some sense for the signal and noise of this. These are individual stacked trials. So this high gamma, we've now just looked at the high gamma window. I'm sorry, this is just 70 to 160. We've gotten rid of the low stuff. We decided we're too dumb for us to deal with right now. 70 to 160, stacked trials. This is stimulus onset. Now they're stacked by motor articulation. So this is when they said bounce real fast, and this is when they said maybe to another verb, noun hit slower. So we've just stacked them. What I want you to see is when they hear the sound, just like we would predict, we get high gamma to every trial in the auditory areas. Okay? As they begin to select the response, we get frontal cortex activation, which spreads to premotor and motor structures as they're going to articulate. And then as they say bounce, as you would expect, same auditory area reactivates. So you're actually tracking, really in real time, this language processing in the cortex. And let me just show you a couple more slides of this to convince you. This is again work done by Eric Edwards, is really the lead person on this, and he was a cog-sci major at UCSD and very non-mathematically challenged. And here's a verb generation task, the same data, a little bit easier to look at. The time frequency plot I just showed you showed the nice single trial stacking. Now we're going to average across the stack, and it's a little bit easier to see. Again, it's rendered on the person's brain. There's the grid. You can't quite see here, but some of the grid dots are grayed out. They're grayed out because they were determined to be epileptic. So we throw them out of the analysis, and I will tell you later that they actually show abnormal coupling. I'm going to show you a coupling measure. So this thing may actually have a side product of being a way for the epileptologist to find coupling. So notice, they hear the noun. It onsets by actually 20 milliseconds. They begin to select the verb, as Larry did, bounce. Middle and inferior frontal cortex is activated. They actually, as they think about it, I don't know what they're doing really, But they go into verb selection areas, which have been shown if you're selecting verbs on fMRI scan in Broca's area. As they begin to produce the pattern, they move up into premotor, and as they motor, and as they say it, they rehear it. Notice also widespread decrease in power in alpha. Alpha drops, it's not as focal. Gamma increases, is extremely focal. So here's a movie of that. This is a movie of that exact distribution you just saw. It's tracking high gamma. It's a 2 seconds of the activity. This is Larry, 2 seconds. Ball, bounce. A 248 millisecond pre-stimulus baseline. There's the bad electrodes that we don't include. You're going to see it come on. And I've spread the movie out over 15 seconds because it happens so fast in real time. And you'll see it go from here to here to here to motor and back. And here's the movie. Onset, boom. 500 milliseconds down in here, up to premotor, up into motor. You articulate it, you hear it. You track language online. And this, we've now done this in 5 of the patients, and they all show the effect. They're slightly different topographies. One other thing for any language people in the audience, there's actually a motor area that comes on when you hear a sound, and that fits with a bunch of theories on the motor theory of language. And I'll just, again, I want you to now focus on this area, which I didn't focus on. When the noun comes on, watch that area come on. On, boom. And that happens in every patient. Okay, and I won't show you the alpha desynchronization. I'll just move on for the sake of time. Stand. Oh, I'm doing good. Okay, so one of our colleagues here, Pascal Fries, has this very influential review paper in Trends in Cognitive Science where he talked about the idea that basically one of the ways for brain areas to interact is to get them in phase and put them in some kind of phase state that would allow better communication between single units. Now, this was first shown in the rodent hippocampus, where you get in spatial navigation, where it's shown that at the trough of theta, you get spike firing, and then Buzzacki showed that you get high gamma in that area at the trough. So the idea is when two areas are in phase with an appropriate phase delay relevant to their conduction time of their axon distance, they can communicate better back and forth. When they're out of phase, they can't communicate. A very simple idea. And we decided to investigate that in our ECOG data. When I say we, this was done principally by Ryan Canolti, a grad student in neuroscience. And I'll show you what he did is he took our ECOG data. This is from 5 subjects. And he took 1-second snippets. And this relates to the question about that low frequency increased theta that we saw. He took 1-second snippets of the data, lined them up by theta trough. So this is the raw ECOG. Okay, by the way, notice the ECOG signals can go up to almost 200 microvolts, which is a dream in terms of analysis, because on the scalp, you're lucky if you get stuff in the 20 microvolt range. He lines each one up. He bandpass filters them between 4 and 8 hertz, and he stacks them all. So they're all stacked, basically. And as you can, these are 36,000 stacked trials from 5 subjects over 11 experiments. Then he basically takes the same data set that he's now aligned and simply bandpass filters it for high gamma. He did 80 to 150. He gets a high gamma amplitude. And what he does is those are lined up, and I think you can see where this is going. There's high gamma increase. If you recall, that's where you had theta trough, and when I put them together, what you can see is that high gamma rides on theta trough, just like spikes ride on theta trough in animal hippocampus, and it's been reported now in frontal cortex. So the next thing that he did is to look at, is there any spatial pattern to this? In other words, is there if we took our 11 tasks and took out the 3 language tasks, do they have coupling in a pattern that's similar in different areas as opposed to our motor tasks? And the answer to that is yes, so that, and I'll just show you the data's a little bit, I want to show you kind of a cartoon structure of what we think is going on. Oh, I'm sorry, excuse me, I jumped the gun. This is the paper that Terry alluded to. This is theta trough. this is this coupling. And I want to point out that the coupling peaks at about 130 hertz. That thing's an artifact. That's 60 hertz line screwing up the signal. But there is coupling at even lower frequencies. So theta is driving a whole range of frequencies, which means the lower end of this, probably up to here, is addressable on the scalp. And I know in my lab, we're going to go back and look at a lot of data sets and see if we've missed this theta-gamma coupling. But really, you need to be on the cortex to see anything above here. And the prime coupling is at a much higher frequency. What he also did is to make sure that the coupling was specific to theta. So here's all possible frequencies looking at all possible coupling. And if you notice, the only frequency that the prime frequency that couples to all other frequencies is really in this theta range. Interesting that it's theta, because LTP is best at theta frequencies, 4 to 5 hertz, in terms of the pulsing intervals. And my colleagues who do transcranial magnetic stimulation say if you really want to make somebody feel out of it, pulse their frontal lobe at about 4 hertz. It's a very disruptive rhythm, suggesting that this 4 hertz is a very key glue rhythm between brain areas. One final thing is this is some new stuff by Eric on spatial coherence on our data set. Again, if we look at distance between electrodes, I'm sorry for the size of this. I just got these slides yesterday. I didn't get a chance to fix them. Distance between electrodes, 2 centimeters, 4 centimeters. Frequency, 2 to about 40 hertz. What you see is the rhythm that is most coherent at the longest inter-electrode distance is, again, right in this wheelhouse of theta between 4 to 8 hertz, basically. So that, you could say, well, if it was just some artifact, you'd expect a lower frequency to have a bigger coherence pattern, and it's not true. It's really selective to that. Because that's not the carrier frequency. That's the key point. Really, if it was just had something to do with, like if it was low frequency, you'd say you have the most coherence and the most theta high gamma coupling during sleep. It's not true. The lower frequencies are not driving it. It's in this band. So this is the idea, not just the idea. This is the data that he came up with. The idea is that if, let's say, you're doing a language task, is that areas involved in language, let's say Broca's and Wernicke's area, maybe parietal lobe, those are in theta phase, and the high gamma is occurring on that theta phase. Now, what does that mean? What's being transmitted? What does the high gamma reflect? I think that's for my animal physiology colleagues to determine, or maybe we will. I don't know. But anyway, that's the idea. Whereas if you switch to a different task, such as a motor task, a different set of brain areas are engaged. So this is a way to not have to use your whole brain. You selectively pick out the areas that you want, put them in theta phase with appropriate conduction delays, and maybe that is an effective way to enhance network communication. Now, since this is a computational modeling, or a lot of computational modelers here, and I'm quite happy to be here, but I'm not a computational modeler, I thought that I had to come up with a model. So I have a model. Can I do a model? Okay. I'm going to do it anyway, even if you say no, because I made the slides and they're hard to make. This is a beautiful, well, whether it's beautiful, this gets back to Quibena's comment about parallel activity in the nervous system. What's always one of the big questions in brain function that's really I've been trying to figure out or understand is how do big coding go between areas so rapidly? A simple line code or frequency code or a rate code on one line, it doesn't do it. It's not combinatorially rich enough. So I'm going to show you an idea about parallel line activity based on these high gamma oscillations. And I'm going to use the human model because it's a perfect way to test it. Here is the areas that I showed where you got phoneme activity and word activity. This is Broca's area where you get speech output activity, and luckily they're connected by a massive fiber bundle. The arcuate fasciculus, and this is a wet dissection. You can actually see the fasciculus. But now with modern imaging techniques, we can do it without dissecting the brain, and we can actually see it. And that's what we're doing on all our epilepsy patients. They get preoperative diffusion tensor imaging, so we know exactly what areas look like they have fiber bundles between them, so we can then correlate that with the gamma activation. So that's what we have. And we know it connects speech input and output areas. So you, Larry, you were so good. Could you do one more thing? All you have to do is when I say a phoneme, say it. Ready? Say pa. Thank you. Okay. Pretty simple, but we don't know how it moved around the brain. Pa arrived here. We know the electrical activity from stimulating here, an evoked response arrives here in 26 milliseconds. That's been determined. So we know the conduction, but you didn't say ba, da, ga. Somehow the code for pa ended up here. It had to, period, or you would have not been able to say it. So the idea is that, and I'm sure it's not correct, actually maybe not positive, but it's probably not, is that maybe we have phoneme modules, and maybe the cortex is organized in little coupled grouped oscillators, where one set of oscillators, 76, 124, 88, and 116, you don't even need that many for the phoneme space, you only need 3, that's pa, or that's ba. And another set of oscillators, maybe 112, 84, 140, 96, that's ga, and so on. And maybe that is how that's a representation. I'm not saying that's how it's extracted initially, but maybe that's the representation of bar ga. And maybe what happens, these coupled oscillator signal is then transmitted on the arcuate fasciculus, where it is faithfully decoded as the pa that Larry very nicely said. So this is testable. Now, I'm not trying to say that the field potentials are going through here. Obviously, spike volleys are going through here. But you could make an argument that different oscillatory frequencies have some subharmonic of spike output, right? That's a reasonable possibility. And there is some evidence that, most of these high-frequency discharges are related to intracortical IPSPs, but they are associated with spike output. I think that there's a lot of work that needs to be done to clarify that. So the idea is that what we're going to do, and this gets back to the first question, we've had the AdTech Corporation made a very nice grid that's being used by Washington University, and we just got 2 of them. It's 2 millimeters by 2 millimeters with a 2.1 intra-electrode spacing. So the idea is we go into and we're about to start this. The first thing that we're doing is putting this grid on the acute cases, and we can't put it where the grid is now because the surgeon is not sure it's going to work. So we're going to put it up above in the hand area in the epilepsy cases, get some data on patients, and do some statistical analysis to see what the independent signal is. Is that area independent from that in terms of whatever frequency band, and we would presume the high frequency band. The next thing is to do the very simple study where you play to the patient's awake, remember. We sit there and we just say to them, say pa, say ba, say da, say ga. And if we could show independent signatures for each particular phoneme that arrived with whatever distortion there might be in terms of the subharmonic change or who knows what, but some reliable ba, da, pa, ga arriving here at 26 to 30 milliseconds, it might suggest that one of the mechanisms for moving large pieces of information around is parallel line communication being reflected in the cortex by high-frequency cortical oscillations. I tried. That's all I can do. Okay, so I want to finish. I think I got 5 minutes, right? Yeah, okay. So let me just show where this is. I think this collaboration with surgeons is really a gold mine, and anybody who can get access to this data, I really think you should, because I think it's going to be a way in 10 or 15 years to fuse the elegant animal literature with human physiology and make some real insights into brain function. So I'm really excited about that. And we're actually talking now about setting up some kind of consortium. For instance, Nathan Crone, the guy that I said discovered the high gamma at Johns Hopkins, we've just decided we're going to collaborate. And when he has a grid patient, a couple grad students from Berkeley will fly out for a week and vice versa. And it'll give us all a bigger N and a bigger data set. So I think, even if you're not at a place that's doing it, you might be able to get involved. So this is the area of brain-machine interface. And I just want to, I think these grids are not just going to go in for epilepsy. I'm going to claim that in 5 years or less, we're going to be inserting grids in paralyzed patients, either high quadriplegic patients or people with intact cortex but subcortical stroke causing hemiparesis, or maybe people with amputations. We're going to be in certain grids and controlling robotic devices. And this is from a review by Nicolalis. Again, if you're going to get Quebena's, which I'm going to get, the Scientific American one, get his Scientific American one in 2002 on brain-machine interface. And I'm going to show you just what's going on in this field. Probably a lot of you know this, but maybe some don't. This is from Nicolalis' lab, a postdoc then, Jose Carmena, who we just recruited to electrical engineering department at Berkeley. I'm very happy to say. This is a PLOS biology paper. And basically, he did an animal task where the animal had, a light came on, and the animal had to move a ball into the circle. Very simple. As they did that, he recorded from 4 motor structures. And when he recorded from those 4 motor structures, he was able to then mathematically extract a way to get 2 dimensions out of the data set in ways using population coding like Georgopoulos' work. So he was able to mathematically extract what the code was. And Carmena is interesting because his PhD at Rockefeller was actually theoretical neuroscience on bat flight, basically. Very, very interesting guy. So let me show you these monkeys performing. And what you got here is the ball's going to come on, and then the monkey has to move the little ball inside. They get a reward. They're recording. It's under arm control, okay? He's moving it. You're going to see him move the cursor. Monkey gets pretty good. Jose's recording single units. Pretty conventional, motor test. A lot of people have done things like this and looked at single unit physiology. Monkey is really very, very good. Okay, so single units in. Now, he trains the monkey through progressive reward to not move the arm, but think about moving the ball, okay, into the thing. You'll see there's no movement, there's no lever. He's still recording from the single units. The single unit brain signals online are controlling the cursor. So watch this. Boom. Not quite as fast as with the arm, but he gets them, right? This is all the monkey thinking about and controlling the single units. This is incredible. So the good thing for me is that we got him to Berkeley because we're not doing a collaborative project where we're doing the implanted patients trying to do control with the high gamma signal, and we can't go into the cortex yet, or at least we're not. My lab's not capable of doing it. We haven't done any single units. We actually have, we theoretically could, but we're doing ECOG, and he's developing an electrode that does ECOG, LFP, and single units. So we'll have a monkey and a human model, and I think we can go back and forth, and it's going to be really exciting. Just to show you that it's not just monkeys that can do this. This is a recent cover on Nature from John Donohue's lab, who's been in the BMI world for quite a while. A multi-contact, you can see this is just a couple millimeters with a ton of single unit probes inserted into motor cortex. For those of you not familiar with MRI scans, the gyri that go that way are frontal cortex, and the gyrus that comes up to the midline, which if you went to a higher cut, the sulcus that comes to the midline is the precentral sulcus, so that's implanted right in motor cortex, this little grid. And that's the patient. This is a high quadriplegic. And I'll just show you his performance on the exact task that Jose did in the monkeys. He has to move the ball to hit the dollar sign. He's quadriplegic. He's controlling it with single unit activity.
That's really great.
And I would recommend anybody who's into this, if you go to